Good afternoon, everybody. My name is Garrett Schmidt, and I am the managing editor for VBC Exhibit Hall. And I'd like to welcome you all to today's live webinar hosted by DataLink. And I'm really excited about this one. It's titled HCC V28, Preparing for the Change, Actionable Strategies from Real-World Analysis. There's going to be a lot of great information here, some practical takeaways, and just glad that you joined us today. I'll introduce our speakers in a moment, but a few items of kind of housekeeping before we get started. Everyone's joined today in listen-only mode, so no need to mute your microphone or turn off your camera or anything. No worries there. But that said, we do want to hear from you, and we're going to have a time for some Q&A towards the end of the presentation, where we can take some audience feedback and answer some questions for you. So if you want to participate in that, or if you have a question anytime during the presentation, go ahead and drop your question in the questions area. Like on your control module, there's a little box for questions, which is different than the chat, but go ahead and utilize that, and we're going to get to as many as we can. If for some reason we don't get to yours, don't worry, someone will reach out via email afterwards, and we'll make sure to get your question answered. And then lastly, the session today is being recorded. So what's going to happen is when we're done, you'll receive an email within the hour, probably after we're done, and it'll have a link to the recording, also where you can download the slides. And there'll be some other information there in terms of how to get in touch with the speakers if you would like to do so. Without further ado, let me go ahead and introduce very briefly our speakers today. We have Mr. Eric Hedrick, and he is the Vice President of Clinical Transformation with DataLink. And we also have Ms. Yasti Puig, and she is the Value-Based Care Manager, also with DataLink. And I'm sure they'll give a little bit more background about themselves. So really excited to have you guys with us. Welcome.
Thanks, Garrett. Yeah, I'll give a little more context on my background here. You can see I've been in the healthcare analytics for 12 years. I did actuarial work for various health plans. Also worked on a few various vendors, mostly around risk adjustment analytics and how that impacts pricing. So I was the guy at the health plan that was responsible for understanding the pricing implications when CMS came out with these new models. And I'm not jealous that I didn't have to do that this year with this version 28 model. And then we have Yasti with us, which we're very fortunate to have. She's been in the industry 25 years, much of that working in practices and educating them. And at DataLink, we're confident that's the path forward is in the risk adjustment industry is how are you going to work with providers to not only ensure that this data is accurately collected through the normal course of care, but also just supporting the delivery of care for those conditions. So we're talking about value-based care. How do we make sure that this care is well managed? And if you're in a risk adjustment department right now and you don't have that line of sight into how practice is actually how the practices perform and how they deliver care by an expert in the industry like Yasti, then I highly encourage you to find yourself a Yasti, but get your own, please. Yasti's ours. So moving on, the first thing I want to do is go through kind of the high level impact of this change, overview of risk adjustment. I think there's various attendees here from coders industry, provider side, and risk adjustment folks on the health plan side. So let's do a really high level overview. Medicare risk adjustment is CMS's way of making sure that the revenue that they're distributing to care for Medicare patients is commensurate with the actual risk and the expected cost of that population. And the way they do that is they take diagnoses from one year, and they use those diagnoses to predict the cost of care to treat those in the following year. And so what that looks like when you really get into the details is that you have diagnosis codes. In 2023, they're mapped to something called hierarchical condition categories, or better known as HCCs. And then those are mapped to some coefficient which correlates with the dollars that you'd expect to care for that condition. And that kind of path of diagnoses to risk score, that has all been kind of rebuilt from the ground up. So they've brand new mappings of diagnosis to HCCs. They've recalibrated all those coefficients, and that's what we're calling the version 28 model. And that model is being phased in over the next few years. And as we go through the presentation today, you'll see it's got some significant impacts in certain cohorts of your population. And so CMS, typically when they do something this disruptive, they phase it in. They don't always follow the plan. You know, there's a chance that they might, you know, phase it in over more years, but we know they've already decided 2023 dates of service will be 33% based on this version 28 model, and 67% of your payment is going to be based on the old version 24 model. So let's get into the details a little bit. We're going to look at a couple examples, and in this change, I'll say is unprecedented in risk adjustment. In the time I've worked in risk adjustment, they've never had a change of this magnitude. So Lori, if you go to the next slide, we've got a couple examples here of disease categories that they've changed. So they've, like I said, they've kind of reworked this, rebuilt it from the ground up. One of the things that they've done differently this year than what they have done in previous examples is this is the first year that they've built their model using ICD-10 diagnosis codes. So the version 24 model, it was originally rolled out in payment year 2020. That was calibrated on ICD-9 codes, and so it didn't have the granularity that you get with ICD-10. And so when you redo that exercise with that higher granularity, what you end up with is you have more granular HCCs. So they're going from 86 HCCs in the version 24 model to 115 in the version 28 model. And then what they've also done is they've renumbered virtually everything, which is great because it adds a bunch of complexity and keeps people like me employed, understanding this stuff and helping health plans and providers through this stuff. But in all seriousness, they've put a bunch of gaps in the model so that in the future, when they do these changes, that they don't have to renumber things. So you can see we've put a couple examples on here. The diabetes disease group, that's always a popular one. This one they've just renumbered. All the definitions are virtually the same. There's a couple diagnoses that changed. That new HCC 35 pancreas transplant, that's not actually a new HCC. They've just moved it from what used to be a transplant group of HCCs. Now they've moved it in there to be next to the diabetes HCCs. But what they have done with diabetes, and I'm sure most of you know if you've looked into this, is that there used to be an incremental increase in risk score if you had complications with your diabetes, and that's going away. They've flattened all the coefficients, and now it doesn't matter if you have HCC 38, 37, or 36, they're all getting the same coefficient. And so what that essentially means is you're going to have a drop in risk score of around what we've seen is around 4%. In members that had diabetes in the past, what their new risk score will be under version 28. And then the heart disease group, you can see an example of how they've increased the granularity here. So they went from 5 different HCCs that are in that heart disease group to now they've doubled it to 10 HCCs. When you look at these coefficients, a lot of them are currently flat, but they've basically given themselves an ability to, in the future, differentiate from end-stage heart disease and heart-assisted device. Those things, they've broken those things out. So this is going to be potentially in the future something where you might have in the past grouped all these conditions together. Now you're going to want to make sure you're looking at specificity in the heart disease area as well. So what does this mean for you? Now, it really depends on where you work. And if your role is in finance, and the rest of this presentation is essentially going to break up through, depending on where your role is or who you're talking to, what do they need to know? And what are the data that we've put together, what does that tell us? And the finance team, they're going to need to understand the impact on future payments, not just overall impact, but program ROI, final settlements, and like the cash flow that happens throughout the year for Medicare Advantage, that's all going to be impacted differently. So they're going to have to be prepared for that. The risk adjustment department, obviously, with these financial changes, you're going to have to adjust your strategy to account for this going forward. And then lastly, where we think the industry is headed and what we're very passionate about is, what does this mean for providers and coders and the whole care delivery system? And we believe at DataLink that this really is the future. And I'll touch on it in a high level, and then we'll have Yasti here to help dig into the details. So first, let's talk finances. Let's get the boring math out of the way first. Overall impact. So let me talk a little bit about methodology here. It's important because CMS usually delivers something called a beneficiary level file that gives you HCCs under both models to help with pricing. But what you want to make sure is that when you do that analysis, that you have a full, complete picture of that year. That means all of your intervention programs are complete, and you can really assess the true impact of going from version 24 to version 28. The other thing that you have to do there is that you have to make sure that both models, if you're going to compare the two, are normalized the same. So CMS releases these normalization factors. You want to make sure that essentially the version 24 and version 28 is normalized to a 1.0 on the same level, so that you're comparing apples to apples. And then finally, you want to make sure that you are digging into not just the overall impact, but what's driving that impact. Finance is going to ask how you can potentially offset that impact. Yasi is going to talk a little more details in that in a few minutes. But what you should know, and what you need to make sure that people around you know, is that although they have added new diagnoses to the model and they've increased some coefficients as well as decreased others, there's not like a very clear, hey, if I just focus now on this category of diagnoses, I can mitigate this impact. This impact is it's going to take a little more creativity to mitigate this than just kind of doubling down on the same programs you've been doing in the past. And I'll also notice, so we did this analysis, and that 1.4% overall change in risk is a number we've come out with, but there's been varying, it depends on the population you're looking at. We've seen some groups of the population actually increase in risk score, and others drop more than 1.4%. And it really depends on how much, it depends on the prevalence of those certain categories of conditions that we'll see in a moment that have been removed from the model. Now, the other thing you want to know about finance is, or you want to let your finance team know about, is that this is going to disproportionately impact some of those settlement payments that you might be used to getting. So for instance, if your health plan or your provider organization is used to be getting some, like a $5 million check every year during the final settlement season, that is going to change in the future. A lot of the CFOs I've worked for in the past have not really paid that close attention to risk adjustment. They rely on other folks to kind of give them those details. And you're going to want to continually remind them that those payments are going to be less, and it's not going to be 1.4% less, it's going to be more than that. And that's because of that second category below, is that the program ROI is going to be disproportionately impacted. You can see we did an analysis of a MRR project there that on the version 24 model, it was worth $13.5 million in impact to the overall revenue of a Medicare Advantage plan. And if you recalculated that impact with just the version 28 model, it reduced it by 30% to $9.4 million. So that because that retrospective program is often involved in that final settlement number, it's going to impact the final settlement number far more than that 1.4% when you look at the overall population. So depending on the other programs that you run, maybe you have like a prospective provider program, in-home assessments, all those programs will have varying impacts. And that's just an analysis that you'll definitely want to do on your own program, because as we get into the next slide, the risk adjustment department during the next pricing season is right around the corner, and you're going to have actuaries coming to you and saying, what can you commit to in terms of revenue associated with risk adjustment? So you're going to want to be prepared to understand how these model changes are impacting the ROI of your programs. And if you're introducing new programs, you want to understand how much of that is going to mitigate the impact there. So this is where the actual impact is much more is much wider depending on the program. We've analyzed different programs and it can vary, but it's always fairly significant. But let me take you through this this visual here on the right, this chart, because I think this is kind of fun if you like charts like me. So what we've done is we've grouped all these HCCs into their clinical groupings, and these clinical groupings are the same ones that they have in the advance notice. So if you go into the advance notice that CMS released and go to about page 50, you'll see that they've categorized version 24 and version 28 into these clinical categories. So that allows us to compare them more easily and roll them up to larger levels. And what we're looking at here is across these clinical groups, what was the prevalence of members that had an HCC in that group in the version 24 model? What's the prevalence in version 28? What's the change in that prevalence? And then the last column shows you what's the average change in risk score for that population of people that were in that clinical group. And that, what I mean by that, and I want to make sure that that's understood because that one's a little bit confusing, but when you look at things like the diabetic changes, so diabetes, if you look about 2/3 of the way down, you can see the prevalence in this population that we looked at didn't change at all. But their risk score dropped by 4.3%. And that's because what we talked about before, where you're not getting that incremental risk associated with those complications. But some of those in the new model, some of those complications are, instead of increasing your diabetes associated risk score, they're triggering an additional HCC that is specific to that complication. And so some of the impact of the diabetes change is offset because you have all these other kind of moving parts happening. So we thought it was best to just kind of look at the sum of those parts and say across your population of folks with diabetes, your drop in risk score associated with those members is a negative 4.3%. So hopefully that made sense. But if we look at some of those examples, you have your first couple on that list, and this is sorted based on the overall impact of the individual members in that population. But that complications, those, I imagine they're likely removed because they're acute and they don't really predict future year costs very well. But it's a low prevalent condition. It's not going to have a huge impact. Similarly with amputations, it's a big drop in prevalence, a significant drop in risk, but it's a low prevalence. And what they're doing here is that previously under the old model, amputation at the knee was treated the same as a toe amputation. And I think we can all agree that if you're missing a toe, it's not the same and it won't require the same future care as if you're missing a leg. So that's an appropriate change. And you'll see that kind of sprinkled in here throughout the presentation, is that a lot of these changes are probably clinically appropriate. I think there's a lot of room for debate around the things like the diabetes change, but if you look at the next one, vascular disease, that one's been a hot topic for years. And we've all kind of known, folks close to kind of CMS and regulatory environment have known this is coming. They're gonna remove these vascular disease, peripheral arterial disease, those conditions that when you go and ask a physician to diagnose them, you get a lot of complaints because it doesn't require any treatment, and nearly everybody in the Medicare Advantage population has that disease. It's just part of aging. So it didn't make sense to code that, and they're finally removing those things from the model. And you can see that vascular disease, it was historically the most prevalent HCC, but the prevalence of that condition is dropping by nearly 90%. And what they're leaving in there is those acute exacerbations of vascular disease. And those things are just far less likely to be missed when you're doing like chart review programs or in-home assessments. Those things acute events, and they're typically well documented. And so that brings me to the second point here that I want to make, is that the ROI of your program, if you look at what are the diagnosis codes that's driving the impact of my program, so if you can look at MRR, for instance, medical record retrieval and review. I often see the top of the list, the most prevalent diagnosis that you pick up as new to that member is vascular disease. And that's going to go away. So all the revenue associated with that also goes away. And so what does that mean to you? Well, I would argue that this long term is going to be good for the program. And this is why I think that. I think that this change is really, it's changing the game for risk adjustment, where it used to be who can find the most people with vascular disease, who can find the most people that give the PQS9 or whatever that major depression screening is, who can give that to the most of their patients and make sure that they're diagnosed with minor depression. That part of the game is going away, and it's turning into, I still have to document all of these conditions, but I'm also going to have to take care of these patients. And that's what the winner is going to be, the person that can do both. And that's what makes me excited about these changes. And they're removing some of the gamification of these programs. So that's what brings us to our next topic we believe the future of this is through working with providers. And so I'm going to talk about kind of high level some of the summaries and some of the dashboards and ways we can drill into this data and the things that we've put together and looked into, and how you might display this to providers. And then Yassi's going to talk through about what does it actually mean when you actually go into a provider's office and ask them to do things differently. What we're looking at here is, you can put this data together and you can make it look pretty. But what Yas is going to say is, like, in the question you often get if you've been in a provider office, okay, what do I need to do about it? What do I do next? What patient do I need to see? They're about action. So, but first, let's look at some of the pretty pictures and numbers and stuff. And first of all, you're going to want to be able to put together the overall impact to their population. And that will look different depending on the type of contract they're in. I've shown on the bottom right here, you're looking at overall risk score impact, and you want to compare that to some sort of benchmark for them so they kind of understand the context to that. But depending on what type of program they're in, you might have to do it a little bit differently. A lot of programs start out with some sort of like recapture rate or chronic revalidation program, where you're just looking at what's their ability to recapture chronic conditions. That's going to look different than an overall risk score impact. So you definitely want to kind of tailor the analysis to what's meaningful to them. And then to the extent that they're available to dig into the details, I think it's kind of nice to be able to present to them the actual diagnosis and member level details. So on the top left there, we have that same chart we looked at before, looking at the kind of the larger clinical categories. But then when you go to the right, we're digging into the actual diagnoses. And what we're seeing there is the prevalence of different diagnoses and what their version 24 HCC is and what their version 28 HCC is, if it still exists. So you can see the diagnoses there are from the musculoskeletal category. Sacroiliitis is not elsewhere classified as going away. So there's 642 patients there that used to have HCC 40 and now won't have that HCC. I can't tell you what clinically that means, but I can tell you that a lot of those not elsewhere classified diagnoses are being removed. And then they're going to want to be able to drill into the member level detail. So that bottom left shows the individual members changes. What are the HCCs, the individual diagnoses they had that map to HCCs historically, and in the new model, what are the new HCCs that they map to? So, it's really great if you have the resources to put this data together. I know a lot of health plans will be able to do this. Provider organizations are far less likely to have this type of resources to dig into the data. But that's why it's good to have Yasti here. She's going to take us through what it actually looks like to drill into those, or to go to the provider's office and use whatever resources you have available. But first, we're going to look at we're going to have a quick polling question to make sure everybody's still paying attention after all that math.
Okay, yeah, so we're going to bring up a polling question here, and so you will see that on your screen momentarily. Let's see. Who's reading this? Oops, one moment, sorry. Here we go. Boom. And the question is, what is your organization's readiness in regards to the change from version 24 to version 28? And we'll show the results here so you can kind of see where your colleagues are. And of course, this is anonymous, so you can be honest, it's okay. We've got some results still coming in, so we'll keep this up for another 10 seconds or so. And results are still coming in, so we'll leave this open for, well, maybe 5 more seconds. 5, 4, 3, 2. They keep rolling in. I don't want to cut everyone off. 2 and 1. Here we go. We're going to go ahead and close it down now, and then we will show.
Wake up your neighbor. The math's over.
Here we go. And I am sharing the results. Eric, are you able to see those?
Yes. Yep. Yeah, and I'll just comment here, whether you're prepared or not, I think it's really critical that if you're in the provider world or if you're in the payer world, the focus of your future is how do we make sure we have strong and trusted line of communication between that payer and the provider, and that's the focus of the rest of our discussion here is how do you work with folks like Yasti in this industry to make sure that that communication is open and that you're getting the information that you need at the point of care, and because that's really going to be the future, and it's much more of an art than a science.
Right. Well, thank you, Eric. I think you hyped that up so much. I hope not to disappoint with the information that I'm about to share with everybody. But as Eric mentioned, there are a lot of changes happening. We went, like he mentioned, 86 payment categories to 115. We went from about 9,700 diagnosis code that used to map to an HCC to about 7,700 now. 2,000 were removed, 200 were added, a lot of information changing, right? But truly, most of the diagnoses that were removed, as Eric said, they were appropriate. They were appropriate to be removed. They were removed due to clinical updates, but there were also about 75 of those diagnoses that were removed due to the Principle 10 updates. And that Principle 10 says that discretionary diagnostic categories should be excluded from that payment module. And we've actually included a little link on the last resource, on a resource page for you at the end of this PowerPoint. As Garrett said, they'll be sharing that with everybody. So you'll have that link on there so that you can read through those guiding principles there. Now, the list that you see on this screen are just some of the most common ones that we're mostly familiar with. So we're talking about categories 107 and 108 that included those atherosclerosis of the aorta. Those have now become category 263, 264, 267, but they mostly now include diagnosis around atherosclerosis with rest pain, atherosclerosis with ulceration or gangrene. These are the ones that are typically more serious cases, as Eric said, that we won't have to be scrubbing the charts so much to go find those diagnoses, because truly they're going to be captured because patients being treated and things are being taken care of. We also see a major change on depression, as Eric mentioned. Just like with vascular disease, depression had over 50% of the diagnosis codes completely removed. Those codes that were left are now limited to the more moderate or severe major depression. Those mild, unspecified, in remission, including bipolar in remission, are now known payment diagnosis codes. You know, the physicians that were helping to create version 28, most of them agreed that anyone having a relapse would be reflected with a more severe active disorder. And that's why those diagnoses were removed. Now, for the ones that were added, we're seeing about 20 benign carcinoid tumors that were added. Anorexia and bulimia nervosa were added, post-polio syndrome, severe persistent asthma. Those among some of the ones that were added. There were a lot of birth trauma and newborn stuff being added into the ACCs. And you don't see those as common, I would say, with the Medicare population. But of course, you'll have those patients that are possibly disabled and things like that, that you will see those diagnoses come through for. Again, there is a great file for this, the ICD-10 mappings. We also provided a link on the resource page for you. This is a great Excel to keep on handy if you're a coder. I actually was able to pull this up, and I went and filtered on the version 28 and only selected those that had version 28 on it. And then I went to the column for version 24 and I removed anything that was on version 24 previously. And it allowed me to see a really good list of all of those diagnosis codes that are brand new to version 28. And this allows you to kind of skim through and kind of get those in the back of your head. So as you're seeing things on your charts, you can capture that. And so I think we have a polling question now that we can look into.
All right. So yes, we do have a polling question, and I'm going to pull this up on your screen for you to vote. So the question is, do you think the change from V24 to V28 will positively or negatively impact patient care? Or there's a neutral choice as well. So we'll give everyone a moment to vote, and then we will show the results. And if you're just not sure, you can just put neutral. Okay, I think we've had most of the results come in. We've still got a few. We'll give it about 5 more seconds here. A long 5 seconds. 5, 4, 3, 2, and 1. And I'm going to go ahead and pull this down now, and then we will show the results. Okay, Yasti, are you able to see the results?
I do. So this is very interesting. Most people thought it's neutral. It's truly not going to negatively or positively impact patient care. And I love that. I love that we're thinking that way. I see that about 32% feel that it's actually going to be positive on patient care and not negatively. I so agree with these results. Thank you so much, Garrett, for showing that. You know, I agree that this isn't going to negatively impact patient care. And if we can put the slides back, that'd be awesome. Truly, there is a negative impact financially, right? As Eric was mentioning, we cannot get away from that. We know that it's going to impact the payers. Ultimately, it's going to impact those contracts with provider groups. We know that there's a financial implication. But the fact of the matter is that it's not going to negatively impact the patient care. And that is the truth. And I love that everybody sees it that way. Now, you know, Eric mentioned that one of the things that we want to do is, you know, how do we think about, well, what do we do next? We know it's happening. We can't get away from it. It is what it is. They removed some, they added some, but what do we do now? The very, very first thing I think that we should do is truly analyze that data, right? As Eric mentioned, look at your population, look at the prevalence of diagnoses, look at how that change is going to actually impact your practice itself. A lot of the larger organizations might have awesome population health tools, sort of like what we've created here at DataLink, with our Evoke 360 population health tool. But some of the smaller organizations may not have those tools at hand. Think about using what you have. Think about using reports out of your EMR. Look for those diagnoses that maybe were coded as unspecified at some point, and go look at those patients chart. Make sure that you have a way to code the right information, right? Make sure that there's documentation on it to maybe pull a more specified code out there. Recapture rates are going to be very, very important now, right? We were used to looking for those calcification of the aorta so that we can get that I-70.0 out there and make sure that we're capturing that. Well, that's kind of going away. So now we've got to refocus. We got to make sure that we are recapturing all of those diagnoses. It is super, super important. So having those reports, having those tools that allow you to see where is your recapture rate right now, where are we at with recapturing all of those diagnoses that were previously coded, make sure that nothing is getting missed. That's going to be super, super important. And I'm going to kind of let Eric talk a little bit about that impact to specific contracts for different provider groups.
Yes, and I touched on this a little bit earlier, but yeah, you just want to, the thing that we're hearing in the market is that a lot of the provider organizations are just aware of this change and they know it's impactful, and they're not sure like how it impacts them personally in their specific contract. So this is really important to keep those providers engaged in your program. One of the most common things that I see that is really undermining the ability for value-based care to be successful is that you have providers that are really kind of unaware of exactly how the contract works, and this is just going to make it worse. And like, they just want to take care of the patients, right? But they know that they have to also keep the lights on. And now there's all these new changes, and they're just learning the HCCs from before, and now they all have new numbers. But the best thing you can do to help put them at ease is to be able to give them specific numbers in terms of how it actually impacts their unique contractual situation.
Absolutely. Thank you, Eric. And Eric mentioned something really important, and that is that the basics haven't changed. We take care of the patient, we document the disease burden. Providers focus on taking care of the members and reporting their conditions. Coders focus on coding based on providers' documentation and the coding guidelines. We don't code because a diagnosis is an HCC, and we don't stop coding because a diagnosis is not longer an ACC. Again, remember, this is being phased in also. For Days of Service 2023, you're getting 6733 of version 24. But for 2024 Dates of Service, you're still getting 33% of version 24, 67% of version 28. So you want to make sure that you continuously focus on everything that needs to be recaptured and nothing gets missed. One of the ways that we can definitely help our providers and our payer partners is by ensuring there is enough support to code to the highest level of specificity. That word always gets me, Eric. Specificity. The Spanish girl in me has a hard time with that one. So, we want to make sure that's enough documentation for, those overweight versus morbid obesity, that asthma versus severe persistent asthma. We want to make sure that we're helping our providers and our provider partners so that if there's ever an audit, this diagnosis have been captured correctly, it has been documented correctly, that there is enough support out there to do that. So, what is our action plan here? What do we do? I'm going to say communicate. Communication with your providers is essential. I remember when I was on the field being a coder, I kind of felt like a lot of the providers thought that the coders were trying to tell them what to do, and it was kind of annoying to them. I had to really work on changing that narrative, and allow them to see me as their support, an extension to them, allowing them, taking some of the burden away so that they actually have a little bit more time in their day so that they can focus on what they do most, that patient care and writing prescriptions and all of the things that they need to do, right? So don't walk into your doctor's office or to your, saying, okay, this is what we're going to do. No, kind of talk to them, ask them how can I help you? Don't just implement something and then don't communicate it to them. I remember one time I walked in a doctor's office, and I was taken over for another coder that had been transitioned out of that office, and all these little stickies kept coming up at me in the EMR, and I asked the doctor, hey, who's putting all these little notes in there for you? He goes, I don't know. They started popping up, so I just get X out of them and get rid of them. So no one told him. So how is this going to be beneficial to this provider if no one's telling him, the process and the plan and what we're doing? So communicate with them. Truly the primary driver of recapture rate is seeing those members. So ensure that you're seeing the right members. Think about that end of the year push. Make sure that you're bringing the patients in that has the most open gaps. But don't think about just MRA. Think about HEDIS too. Make sure that you're communicating on all of those open gaps. One of our reports in our Evoke 360s are clinical care gap report. I love this report because it allows the provider group to see not just the open gaps for MRA, but it also allows them to see those HEDIS open gaps that they also have to address during the visit, right? So we want to make sure that we're putting this in front of the provider so they can address all of these gaps in care. I must be an unusual coder, but I love HEDIS. I think sometimes I love HEDIS a little bit more than I do HCC MRA coding. So ensure that your providers have the information that they need. And if you're scrubbing the charts, look for those HEDIS open gaps as well. And if you're finding those colonoscopies on there, find a way to submit it to the health plans to close those gaps in care as well. Us coders, we're looking at every piece of paper in that chart. And, we're losing a little bit of funding on the MRA. So let's make it up to ensuring that we're getting those bonuses for HEDIS and we're closing all those gaps in care for HEDIS as well. So think about your prospective chart reviews. Make sure that you're looking at everything in there and letting the providers know, be able to communicate this in an effective way so that they have the information that they need when this patient comes into the office, right? Build on provider education activity. Think outside the box, make it fun, make it appropriate. I remember going into a doctor's office one time and I was going to educate him on diabetes. And I thought about, I stopped at a gas station and brought in a candy bar and say, hey, we're going to talk about diabetes. So I brought you a chocolate bar. He got a kick out of it. I did too. We laughed. It made it memorable. It allowed him to remember that we talked about diabetes and hopefully remember all the things that we talked about diabetes. Think about talking to them and showing them their documentation. Don't focus on just the negatives. Half the time we coders come in to educate them and we bring all of the bad documentation that we found out of hundreds of patients that they saw where the documentation was great. We nitpick at one or two documentation that they lacked on and we bring that in. So we want to make sure that we focus on the positive as well, not just the negative. And I think we're getting towards the end here. So I'm going to try and wrap it up so we have a little bit of time for questions. But again, think about keeping it simple, right? Remember that KISS principle, keep it simple, sweetie. Just focus on one or two things that you want to talk to them about. Show them the real data, show them how this impacts their practice. And if we go ahead and go to the next slide here, for those large organizations or even managers and administrators, how can you support your coding team? One of the things that I love about working here at DataLink is that our managers, our leaders are always looking for ways for us as employees to develop ourselves, to learn more. They buy memberships for us to learn and develop ourselves. And one of the things that we're encouraged to do is to schedule that time. Put an hour on your calendar every week when you're actually looking increasing and developing your knowledge and looking into these changes, looking at the diagnosis and things like that. You know, our payer partners have great webinars. Aetna and Humana, I know, have amazing MRA, HCC webinars that are free. Anybody can register for them, and you get 1 CEU for each one of those. So take advantage of that. Take advantage of learning those. And of course, they tell us, read our guidelines every year. But I don't know if you're like me. I sit there and try to read my guidelines, my coding guidelines, and 5 minutes into it, I'm thinking about what I'm cooking for dinner. So I found a trick, and that is that I go to YouTube, and there's always someone that goes through and reads those guidelines with you. But it allows me to, you know, kind of keep myself a little bit more engaged and make notes about the coding changes and things like that. You know, another thing that you really can do for your coders is make sure that you have up-to-date coding books. Make sure that you offer tuition reimbursement, offer a great software, a great population health tools sort of like Evoke 360. Make sure that you have those diagnosis mapping available for them. You know, as coders, we're not clinicians, right? And we should not be making clinical interpretations, but we should definitely be knowledgeable on what to look for. So, you know, build relationship with your providers instead of you educating them all the time about, you know, diagnosis and documentation. Have them educate you on how to help them look for those suspecting conditions. You know, I did find a provider one time that he loved doing that. He loved teaching. So I tapped into that. Every time I went into his office, I was like, okay, teach me something. What can I help you find in this chart? You know, and he loved that. It allowed us to build a great relationship. Again, ask, how can I help you as the providers, you know, close these gaps in care? As administrator, create cheat sheets. Create a great SharePoint, but make it simple, make it easy for the coders to find things. I used to work at a large organization that had great information, but it took me forever to find anything on that SharePoint. Make it simple, make it easy for them, and keep it updated. If you're a smaller practice, maybe keep a little binder or something where your coders can find that information. And as we wrap it up, I want to encourage you, you know, focus on the positive. You know, all of these changes, to me, I feel like as a coder, it's going to create less provider abrasion. You know, we're not continuously asking them to code things that they really are not doing anything about. Focus on the fact there are many other things that are in fact remaining: your cancers, your diabetes, your morbid obesity, your cirrhosis of the liver, your emphysemas, your other primary thrombocytopenias, your major depressions, you know, your heart failures. All of these things are staying, and it allows us to ensure that we are truly capturing good documentation to ensure that we're protecting not only our providers, but we're protecting our payer partners as well. There's going to be less chart chasing. And if you're like me, you're going to be able to focus on what you love, that documentation and that specificity. So with that, I'm going to hand it over back to Garrett. Hopefully this has helped some people. Again, there's lots of resources that are going to come your way, and we're just going to go ahead and open it up for questions. Thank you, Garrett.
Yes, and we did have a lot of questions that came in. So if you have a question at this time for either of our speakers or just in general, go ahead and ask it now. You can use your control module. There's a place for questions there, so drop it in there. We're going to get to as many as we can. If we don't get to yours, it's okay. Someone will reach out to you directly via email to answer your question. So in no particular order, let's start with this one. Will V28 reduce the impact of increased diagnostic coding accuracy or efficiency?
So reduce the impact of increasing the efficiency. So I think where they're going at is you know, like if you have a provider that's very engaged with this and they're coding at a high specificity, will this impact their risk score and basically nullify the impact that you've historically seen from that? And the answer is, you know, if you have a provider that's highly engaged with this type of work, they're probably also a provider that's looking for those atherosclerosis of the aorta that a lot of providers miss. And so all of the work they're doing to make sure they're documenting that disease, even though they might not be doing anything to manage it, that the value of that is going to go away eventually. But what you want to make sure is that you want to frame this as, you know, we still want to manage that the care of that patient. We still want to document their disease burden to the full specificity, because even though, you know, the next year it's only going to be a 33% impact, you know, the old HCC, that vascular disease is still going to be it's still going to be there, but only at a 33% level. We don't know what CMS is going to do. That's the plan right now. It's highly, you know, I would not be surprised if CMS came out next year and decided to do like a 50-50. So they can still change that. So going into 2024, you still want to document those things. But yes, absolutely. What we see is that when we look at individual impacts at different provider group levels, it tends to be the providers that are highly engaged are seeing a greater impact, unfortunately.
Great. Okay, next question here is, will the loss of HCC MRA revenue lead to an increase in upcoding?
I don't think there's a big risk of upcoding because of all the OIG and Department of Justice lawsuits that have been going out there. I think that what it'll be an increase of is health plans wanting to do work more with their providers and documenting disease burdens at the point of care, and hopefully setting up programs to rely less on chart retrieval programs and in-home assessments in the future.
Great. Sounds like a delivery arrived. Okay. Next question is, you mentioned normalizing the RAF score to 1. Does this mean bringing a patient's RAF score to only average around 1?
So what that means is that when CMS calibrates these risk score models, they kind of train it on a year of the population. So maybe they're looking at 2022 dates of service for their Medicare population, and they calibrate that risk score. And the way that model works is that a 1.0 means you are the average risk of 2022 population. But when you then go apply that same model on a different year, you have to understand how the morbidity has changed, and you have to recalibrate it back to a 1.0, because that's essentially how CMS does this, is they keep it quote unquote budget neutral by saying a 1.0 is, you know, we're always going to try to average it so that the 1.0 is the average risk of the whole population for the year that in which we're applying this. And so if you go look at the advance notice and in the final notice, they publish a normalization factor that essentially tells you what they're going to do to everybody's risk score so that a 1.0 becomes the average. And when I talked about normalization, you want to apply the appropriate normalization to both the version 24 model and version 28 model. So the year that you're looking at, they both have a 1.0 risk score. Otherwise, your comparison will be off by the significant magnitude.
Great. We have time for one more question. Again, we have had a lot of questions that are coming in, so I'm sorry if we're not able to get to yours. Please go ahead and ask it, though. Someone will reach out to you to answer your question. But the last one that I wanted to stop on here, and I promise this isn't a seed question, even though it sounds like it, is if we have not started to plan for this change yet, what do you recommend we do first to start prepping?
So it depends on if you're a health plan or a provider organization. I think at the provider organization level, you just kind of want to review, you probably want to focus on recapture rates. And so you want to load, like Yasti talked about, that Excel file that's available that shows the mapping of version 24 and version 28 at the ICD code level. You want to download that, compare it to your population, and see, you know, what do I need to make sure I'm recapturing on both models, right? And see how that impacts your population, because that's at the provider level, you're really talking about what patients do I need to see, and who do I need to get in through the door. At the health plan level, if you haven't started doing this work yet, you really need to do the financial analytics to understand how it impacts your population, what it means for pricing, especially if you're in a risk adjustment department. You're always tapped on the shoulder asking for how much you can help them offset premium decreases and what you can commit to for supporting any sort of revenue shortfalls. And your ability to do that with the same tools you've used in the past is going to be impacted. And so you need to be prepared for those discussions.
Wonderful. Wonderful. Well, unfortunately, that is all the time we have. And again, there's still questions coming in. So obviously, this is a really hot topic. Want to thank our speakers today for this information. It's a weedy topic, and there's a lot here, as you can see. And we're going to be sending out a link to the recording, to the slides, where you can download those later on, so you can rewatch it, share it with your colleagues, and we hope that you do. But real quick, as we close, I wanted to encourage you all to head over to the vbcexhibithall.com, and here's where you will be able to visit the DataLink virtual exhibit booth, which is really cool. You can take a look at it here on your screen, and this is a place where you can engage with the team. There's a lot of cool resources that you can utilize and look at, and that way just really educate yourself on them and what they're doing and how they can help. And if you're in the process of or need any help or support in this process, please feel free to reach out to them. Speaking of, if you'd like to reach out to our speakers, their information, well, at least the general information is here on the slide, so you can reach out there and they'll put you in touch, or feel free to reach out to me. And I'm happy to facilitate an introduction for you. So thank you again, everyone, for joining us today. Thank you again to our speakers. This was a very informative topic. I know I got a lot out of it, and appreciate you all spending your afternoons with us. So have a wonderful rest of your days, and we'll see you on the next webinar. Bye-bye now.
Thanks, Garrett.